guys. Okay, welcome to week 2. So this week, I think we're going to start with some PHYS. We want to go to the next slide. Yeah, there we go. So we're going to start with some PHYS. So we're going to start with sensory and then motor systems, and then we'll touch on some clinical skills. So specifically the examination of the motor system and the upper limb. And then I think we'll wrap up your upper limb anatomy as well. So we'll start with the intro to sensory systems. The first thing is the idea of receptors. So there's 2 ways that we can classify receptors that can be based on the origin of a stimulus or the type of a stimulus that will interact with those receptors. So if we classify based on the origin, we have exteroception and interoception. So the first one being from outside of your body, the second one from being inside of your body. And then proprioception is related to our body's relationship with the space around it. Then if we classify it based on the type of stimulus, we have mechanoreceptors, photoreceptors, chemoreceptors, thermoreceptors, and nociceptors. And I've chucked in there what stimulus they will respond to. We have the 5 different sensors on the side there and which receptors are involved in detecting those stimuli. And then down the bottom, we have other key sensations like proprioception and pain and thermoreception, which are detected by proprioceptors, nociceptors, and thermoreceptors. So the journey of a sensation, so how it's converted from a stimulus to how our brain will then interpret certain signals. So it starts off with accessory structures. So this could be like the sensory organ that is going to receive the stimulus energy. That stimulus energy will then be converted to a receptor potential by receptors, and then that will be converted into an action potential. That'll travel to the central sensory components. So it can result in things like motor responses or contribute to your learning and memory and any other cognitive processes. So in general, most sensations will travel from the sense organ. It will go to your thalamus and then to the respective sensory cortex. So for example, with vision, that stimulus will go from your eyes to the thalamus and then the visual cortex. The key exception, would be the olfactory or smell sensation. So that one does not go to the thalamus, but it'll go to the olfactory cortex directly. Okay, so we have 3 different sensory systems, and pretty much all of them will convert a stimulus into a receptor potential. That will be converted into an action potential, and then that action potential will travel to the CNS. So the type 1 system, we have just one nerve, and that nerve has a specialized nerve ending, which will generate a receptor potential at the nerve ending. And that same nerve will then produce an action potential, which will travel to the CNS. But with the type 2 system, we have a receptor cell on its own, and that will produce the receptor potential. And then it will communicate with a nearby nerve fiber through chemical transmission. So that's things like releasing neurotransmitters and stuff. And then that nerve fiber will produce an action potential. In the type 3 system, it's very similar to type 2. So you have the receptor cell, which will produce a receptor potential, and then a nerve fiber that will produce an action potential. But then there's an intermediate cell in the middle that will convey the information, again, through chemical transmission or neurotransmitters. So how a receptor will detect a sensation? We'll start first with a receptor cell itself. So a receptor cell is an electrically polarized cell, which pretty much means the charge inside the cell is different to the charge outside. And specifically with receptor cells, the inside is more negative than the outside. So there is a resting membrane potential in receptor cells, and this occurs because the membrane has a lot of leaky ion channels. So you have this constant flow of ions in and out of the membrane, and that'll cause a flow of current that's always present, even if there's no stimulus activating the receptor. So in terms of actually activating the receptor cell, there needs to be a change in that resting membrane potential. So that can be either a depolarization or a hyperpolarization. So it can occur both ways, but most commonly throughout your body, it will involve depolarization because activating a receptor cell will usually lead to the influx of sodium. So there's two different types. If you want to go back, there's two different ways of activating a receptor cell. There's a direct pathway and an indirect pathway. So in the direct pathway, the stimulus will interact with the receptor cell and it will result in some kind of change to the membrane itself. So that could mean that the permeability to ions will change because channels are opening and closing, or in some cases, like in stretch receptors, the actual membrane will be physically stretched. And that's going to result in a change to ions in and out, the ion flow in and out of the membrane, and that will create a change from that resting membrane potential, resulting in a receptor potential being produced. And in the indirect pathway, it's very similar, except at the start, the stimulus is going to activate certain secondary molecules like a G protein, and that molecule will cause the change in the ion permeability. Okay, so I'm not going to touch on this table too much, but it's good to not only compare properties of the receptor potential to the action potential, but it highlights some key features of the receptor potential. So things like the fact that the channels are chemically and mechanically gated as opposed to voltage gated, and also the fact that it's graded. And we'll look in the next few slides how the graded nature of a receptor potential is really important in conveying certain information about a stimuli. So, sensory coding. Coding is pretty much where a receptor potential is going to be converted into a pattern of action potentials. And that pattern of action potentials can convey different parts of information about the stimulus. So the first one is intensity. There's two different ways the brain can interpret this information. So one is if we activate the receptors more. So if a stimulus is stronger, more ion channels are going to open. That's going to cause a greater change in the ionic movement, a larger resting membrane potential, then a larger receptor potential, and an increased frequency of action potentials. And so your brain interprets the increased frequency of action potentials as a stronger stimulus. So how we go from a larger receptor potential to then an increased frequency of action potentials, I think is shown well in the picture in like the middle of the screen. So on the left-hand side, the left spike on the receptor potential, you can kind of see that it doesn't hit the action potential threshold, which is the red line that's going across. So there's no action potential that's being produced. But then the middle spike, it does go past that line and it will produce some action potentials. And then on the right-hand spike, you can see that the receptor potential goes above that line, not only for longer, but to a greater degree. And because it goes above the line to a greater degree, we get a much greater frequency of action potentials being produced. So the second way is, if we want to go back, the second way is to activate less sensitive fibers. So there are different nerve fibers that have different sensitivities to a stimulus. So pretty much a stronger stimulus will activate the less sensitive fibers, whereas the weaker stimuli will only activate the more sensitive fibers. So as a stimulus increases in strength, there's this combined and cumulative activation of nerve fibers, which have different sensitivities. And again, that's going to lead to an increased frequency of action potentials, and your brain is going to interpret that as a stronger stimulus. Okay, and then we have the duration. So how to convey information about the timing of a stimulus. So again, kind of what I mentioned in the last slide, an action potential will only be produced if that receptor potential reaches the threshold. So in a closely spaced stimuli, you can see on the bottom left-hand picture, there is a summation of the resting potential, because you have the first receptor potential going up, and before it can come back down, the stimulus triggers the receptor again, and you get another receptor potential being generated. So they kind of add on to each other, and you get a larger total receptor potential, and that's going to increase the frequency of action potentials that come out. This is different to if you have stimuli that are kind of spaced out a bit more, because the first receptor potential can kind of reach back to baseline before another receptor potential is produced. So the action potentials are occurring less frequently. Okay, in terms of conveying information about change and adaptation, there are two specific nerve fibers. So there's phasic and tonic nerve fibers. Phasic nerve fibers are important to detect any changes in a stimulus, so any changes in the intensity or the rate. And this is because they adapt very quickly to new stimuli or changes in a stimuli. So on the bottom one in the picture, you can see that when the stimulus starts, the action potentials in a phasic nerve start to fire, but then they'll drop off eventually if the stimulus is not changing. Whereas with tonic fibers, they adapt a lot more slowly to stimuli. So there's this kind of constant and sustained signal for the duration of the stimulus. So that's going to give your brain information about how long a stimulus is lasting for. Then we have the location. So a receptor field is pretty much a collection of receptors that activate one specific nerve. So in the photo, you can see that one receptor field is like one of those red circles, and any receptor in that red circle, if it's activated, it will all kind of converge onto that one sensory nerve. And your brain, if it receives information or signals from that sensory nerve, will interpret that sensation to come from the specific receptor field. So that's pretty much how those action potentials convey information about the location of the stimuli. You'll come across this concept a lot in terms of the somatosensory system. So things like touch, especially in clinical skills, when you talk about the 2-point discrimination test, which I won't go into, but you'll see it in the next few weeks. But also keep in mind that this does happen also with vision and your hearing. We tend to have smaller receptor fields in places where we need to detect more detail, but so that would include things like your fingers, but in places like your legs or your thighs, you would have larger receptor fields. I think that's pretty much all. Yeah.
Yeah, okay, so I'm going to be giving you guys an intro into skeletal muscles. So yeah, so we'll start with just like a general image of what a muscle looks like and kind of break it down. So there's a few layers to a muscle. It starts with an epimysium, which is kind of the outside, and then as you go in, you get the perimysium, and then you get the fascicle, which is kind of the fascia that surrounds the sarcolemma. Oh, shit, no, that's wrong. Fascicle kind of has a bunch of muscle fibers inside it, and then inside a muscle fiber, there's a bunch of myofibrils, which is a lot of new words that you kind of aren't used to. So I'm going to go through some basic definitions. But before that, I'll start with kind of just a few basic things. Fiber in muscular physiology is synonymous with cell. So you might see muscle fiber or muscle cell. It means the same thing. From outermost to innermost, you get epimysium and then perimysium and then endomysium. So from your study of epithelium, you probably experienced endothelium. So that's kind of how I remember that that should be the most inside, or like the innermost layer. Tendons attach whole muscles to a bone, but that's not really relevant to the physiology. It's kind of just for the anatomy. And a single muscle fiber or cell consists of many myofibrils, which is what we're going to get into today. So let's look at some basic definitions. I've accompanied this with an image to kind of help you visualize a single muscle cell. So this is one cell. As you can see, it's kind of arranged in like a circular, like a circle. So all the myofibrils, which are bundles of parallel contractile filaments, I know that's a mouthful, but again, I'll get into it in a bit, kind of line themselves up in a circle. This helps with kind of contracting in unison and making sure that everything runs at the same time in parallel coordination, okay? So there's going to be a few new terms here. So you might have heard of plasma membrane or endoplasmic reticulum. In muscles, it's changed to sarcolemma instead of plasma membrane. So a sarcolemma is the outer surface of a myocyte or a muscle cell, and it's capable of conducting an action potential. Okay? So it forms neuromuscular junctions with neurons and serves as the plasma membrane of these cells. Alongside this is the sarcoplasmic reticulum. So again, synonymous, or not synonymous, but kind of like the endoplasmic reticulum. In this case, it's only used for muscle storage. So it's a very specialized, smooth endoplasmic reticulum. Now, the last thing you'll need to know is what a transverse tubule is. So if you look at the bottom image, you can kind of see the transverse tubules there in between two terminal cisternae, which are part of, or like the ends of the sarcoplasmic reticulum. Now, those two things in combination form what's called a triad. So two terminal cisternae and a T-tubule. And I'll get into why that's important in a bit, but just for general sense, it's basically important that those two are lined up together for coordination of contraction. But let's continue. So let's look at the very basics of muscle fibers and physiology. So this is actually physiology here. So myofibrils are the small components that make up each muscle cell, can be divided into sarcomeres. So this is kind of the first word that's actually really important, kind of a high yield word, if you will. So a sarcomere is basically the smallest repetitive contractile unit. So smallest, basically what you can see in the top image. So if you look at that, I'll explain what they all are, but if you look at that Z disc, so the distance between each Z disc is basically a sarcomere, okay? So if you, a sarcomere is the smallest distance between the two Z discs. Now, what is a sarcomere and what is inside it? So they have, all sarcomeres basically have a consistent structure and they all look like the image provided. So if we look at an A band, so an A band, I provided the kind of the radiograph as well, so you can see kind of more clearly how it's supposed to look. So the A band is kind of what we call the thick band because it contains both actin and myosin. Okay? So those are the two filaments that are going to make up the majority of muscle fibers. There's also another one. The name is not coming to mind right now, but it's not very important. I think it's elastin, so that's not very important. But myosin and actin are basically what's going to be helping our muscles contract. So the A zone or the A band is what is the zone in which the myosin and actin overlap. The I band is a period of only actin filaments. The H zone is the period. In the first image, you can kind of see there's no overlap at one point, and that's going to be your H zone. Your Z disc or Z line is going to be the edge of the sarcomere, and the M line is the middle of the sarcomere. So I think it's more clearly represented in the bottom image. So you can kind of see that the A band is much darker because it's got both. And you can kind of see the M zone and the H zone kind of in the middle of the A band. And you can also see the I band, which is only actin. And you can see that it's much lighter because actin is the thin filament, and by itself, it's much lighter than the comparison. Now, if you look at the Z line as well, you can see that that's the boundary of the sarcomere or the contractile unit. So the sarcomere is basically from the first thick dark line with the Z on it to the other one. And it's just repeating over and over again. Okay, so what are the proteins of the sarcomere? So the main ones here are going to be actin, which is the thin filament, tropomyosin, troponin, and myosin. So I'm going to get into tropomyosin and troponin in a little bit, but we'll start with myosin. So myosin provides the moving part of the muscle and is the structure of the thick filaments. So whenever we're talking about contraction, basically we're talking about the movement of myosin. Now, how does that actually happen? If we look at it, we're looking at two things. So tropomyosin covers up binding sites on the actin filament, and troponin is used to remove them. So kind of they're used in conjunction to relax or contract our muscle fibers, okay? So in a relaxed state, let me just see. Okay. Yeah, I'll give you a general description. I go into a bit more detail later, but basically in a relaxed state, the tropomyosin is covering up binding sites on the actin filament. And in a state where you want to contract, troponin is going to bind to tropomyosin and remove it from the actin filaments, and thus allowing the actin to bind to myosin and allow contraction to occur. Okay, so that's kind of how they all work in conjunction to each other. So actin and myosin are the main filaments, and troponin and tropomyosin kind of regulate the ability for them to bind together, I guess. So the next slide. Okay, so on the next slide, I've picked these two images because I think they kind of describe it well. Now, I do explain it in words as well, but this is kind of just for a general visual understanding. So excitation contraction coupling was kind of like the main key objective of this lecture. So I'm pretty sure this is kind of what Michael wanted you guys to know. So how does it work? So basically what's happening is an action potential arrives to the end of a cell, and then this causes acetylcholine to move across the neuromuscular junction and bind to synaptic receptors and spread the action potential into the next cell. Okay, that's how it starts. So it starts with acetylcholine being a neurotransmitter and sending down an action potential. Okay, the action potential is going to move down the muscle cell, right? It's going to travel down the transverse tubules, and at the same time, calcium is going to be released from the sarcoplasmic reticulum. Okay, so this is in response to the change in voltage. So remember before when I said there was a triad of two, what are they called? Oh my God. Of two terminal cisternae and a transverse tubule. So the action potential travels down the transverse tubule, and the calcium is traveling through the sarcoplasmic reticulum through the terminal cisternae, parallel to the action potential. So it kind of happens at the same time. Okay? So calcium then binds to troponin. So before how I said that troponin has to bind to tropomyosin, basically what's going to happen is calcium binds to troponin, and that allows the tropomyosin to be removed, and then you get the power stroke going. So I'll explain all of that in a bit more detail. This is just kind of what I want you guys to do is after I finish explaining, like come back to this image, and then it will kind of be like a good summary. So yeah, so let's start with excitations. How does it actually work? Yeah, next slide. Yeah, okay. So how does it actually work? So I've already described basically how it works, but in a bit more detail, you can see that sodium channels open up, which allow an influx of sodium into the cell. And this works like another action potential and depolarizes the muscle cell. So this is what causes the depolarization to spread down the transverse tubule. And another thing that's kind of important is the understanding of DHP and ranitidine receptors. So these two receptors allow calcium ions to leave the sarcoplasmic reticulum and bind to troponin, okay? So kind of all of it works in conjunction with each other, but the basic understanding of excitation is that a action potential arrives at the end of one cell, synapses across using acetylcholine, and then causes depolarization of the muscle cell, which then spreads down the cell and simultaneously releases calcium to bind to troponin, which then binds to tropomyosin to initiate power stroke. So let's go to the next slide. So this is kind of the really important stuff to understand here. So contraction and cross-bridge cycling. So how does it kind of work? This is probably the main kind of high yield stuff that you need to understand, well, alongside what I just explained. But at rest, tropomyosin and troponin block the active sites on actin, so we already know that, right? So what happens now is the calcium is released, binds to troponin, and pulls the tropomyosin away from the actin, which reveals the active site. So once we have that going for us, then muscle contraction is ready to happen. So the first step that's really important is the removal of tropomyosin, okay? So what happens then is the myosin heads, and you can follow this kind of in the image. So the first step, well, the first thing I've described is step 2, and then you go to step 3. So basically myosin heads hydrolyze an ATP molecule to reorient in preparation for contraction. So basically, I think it's described as being cocked back. So the myosin head kind of rotates forward, okay? And as a result, ADP is released because in order to move the myosin that way, ATP had to be used, okay? So kind of understanding where the inputs of energy and the outputs of energy are really important, okay? So here you can see that in order to cock back the myosin, you have to use an ATP molecule, okay? After this, myosin binds to the active sites, and that's when a cross bridge is formed, okay? So basically, a cross bridge is when myosin binds to the actin finally, okay? Now, what happens then is the myosin rotates forward and shortens the muscle, okay? So that's technically not a very good description, and I'll explain why in a little bit, but contraction is kind of understood as you're making something shorter, but what's actually happening is something slightly different. But for your understanding at this point, I think understanding that it's shortened is fine, okay? Now, after the shortening happens, then what's going to happen is ADP plus PI is going to reform ATP, and then you're going to get the myosin going back to what it originally was, okay? Now, the power stroke is basically that third dot point where the myosin bends itself forward to shorten the muscle, okay? So that's called a power stroke. Now, I think it's better described a bit later, but yeah, I'll go into that a bit later as well, okay? But that's basically cross-bridge cycling. Now, after contraction, you're going to have relaxation. So the 3 stages, Ethan, next. Okay, so the 3 stages of kind of a muscle contraction are excitation, contraction, and then the final stage is relaxation. So everything kind of goes back to the way it was. So in the absence of acetylcholine in the neuromuscular junction, or any stimulation or the traveling of any action potentials, then basically what's going to happen is the ACH esterases are going to remove acetylcholine from the neuromuscular junction, and that's going to end depolarization, okay? So when there's no more depolarization, the DHP and ranitidine receptors close, and that stops calcium release, and as a result, the tropomyosin then binds to the actin and closes it all up. So it's kind of literally the exact reverse of what happens during excitation. So yeah, it's a pretty nice little system that we have going. Now the last thing quickly is rigor mortis. So basically ATP is required for myosin to unbind from actin. So this means that in death, the lack of energy, because there's no more energy being produced when you die, causes the muscles to be stuck in a contracted state. So for a few hours until the muscle fibers eventually break down. So when you guys will probably see this in a workshop later, but just for your understanding, because the person can't produce ATP anymore, they can't unbind the myosin from actin, and their muscles are going to be very rigid and contracted for a few hours after death. Okay, so now we're going to try and put it all together. So we've got excitation, contraction, and relaxation, and we're all going to put it into one kind of image in the sliding filament theory. Okay, so muscle contraction is caused by the sliding of actin and myosin. Everything inside the muscle stays the same length. So before, when I said it shortens, that's kind of not true. Basically, what's happening is the actin is being pulled over the myosin. So in that image where a few slides ago, don't worry about going back, but a few slides ago, the image where the myosin kind of bends itself forward and uses ATP. So that's going to be what's causing the muscles to contract. So that's sliding filament theory. So when they bind, so the myosin binds to the actin, pretend it's like this, or I guess like this. Oh no, actually no, like this, right? And then what happens is it uses ATP and it pulls the actin like this, and the actin kind of comes closer together, and that's how the muscles shorten. Okay, so this is kind of depicted in the first image. So you can kind of see how the actin covers the majority of the myosin during a contracted state, because the myosin heads have pulled actin closer together, okay, in order to get some tension and contraction. Now, there is such thing as a length tension relationship, and this diagram is pretty important as well. Okay, so what we want for ideal like tension and length is for when we contract, the actin heads basically just meet, because that means that all of the potential space available is being used for contraction and building tension. Okay. Now, let's just say, for example, if you look at the bottom image and we look at A, this is in a relaxed state. You can see that they're already overlapping, right? If you're already overlapping and then you contract, you're not going to gain anything because it's already in maximum tension. Okay, so it's very, very bad for muscle strength. Now, if you look at B, it's a little bit better because there's, even though it's like still touching, there's room for overlap and you can build a bit more tension. Okay, but C is ideal because what happens here is when you contract, you're bringing the actin fibers as close together as possible without overlapping, so that there's no wasted space of myosin and maximum contraction, and that leads to maximum strength. And that is kind of why, that is why our muscle fibers kind of look like that. Now, following the same story, if you make it too long, then you're not going to have enough overlap to build tension, and E is just ridiculous. Like that's just not even feasible. You're going to have no tension when you contract, so there's no point. But remember the shape of that graph, because it's, again, pretty high yield stuff. Look at that. Yeah. So the last thing I'm going to leave you with is different types of contraction. So isotonic versus isometric. What does that actually mean? Isotonic means so T for tension. Okay. So isotonic means the muscle changes length, but the muscle maintains a constant tension. Okay. So an example for that is doing a bicep curl. When you've got the dumbbell in your hand, you're already contracting, but the muscle shortens as you bring it closer to yourself. As a result, you're getting a isometric contraction. No, I lied. You're getting an isotonic contraction. Now, isometric contraction means, or metric muscle, so muscle changes tension without changing length. So I just think metric system is meters and distance. So there you go. Doesn't change length. Now, in isometric contractions, cross-bridge cycling still occurs. So even though contraction is happening, they just rebind in the same place. So it's still creating tension, but it's just not shortening the muscle length. Okay. Now, concentric versus eccentric. Basically, concentric contraction is where the muscle shortens while contracting, whereas eccentric is where the muscle lengthens. So basic examples of concentric is, again, a bicep curl, because like you do this motion and your bicep is going to curl up and become shorter. And eccentric, maybe like a tricep extension. You like go from here downwards and you can feel the muscle lengthen. Now, the last one is basically a good example for when the muscle is not shortened but tension increases is so some people are like, well, whenever you like contract, you feel like your muscle's shortening. But a good example for that is kind of when you're holding like a bunch of grocery bags in your hands and you're carrying it inside your house from the garage. Basically, what's happening is your muscle is tensing so that you can hold the garbage, the grocery bags. But because you're just keeping your arm in a fixed position and straight, you're not actually changing the length of your muscle. A way for you to feel this is kind of if you just hold your arm out and then just like squeeze your fist. And if you feel over your bicep, you'll feel that it's like tensing, but you're not actually shortening the muscle length. You're just increasing the tension. But yeah, that's it.
Okay, so I'll talk a bit about neural integration now. So neural integration is pretty much all about how different areas of our brain control movement. So there's three main parts that are discussed in your lecture. There's the motor cortex, the basal ganglia, and the cerebellum, and they all have three different roles that they play in controlling movement. So the motor cortex is more involved in creating and planning the actual movement, whereas the basal ganglia is more involved in inhibiting any unwanted movements. And that will help to allow the movements to be more smooth and fluid. And then the cerebellum is really important for the coordination of those movements. The motor cortex can be divided into area 4 and area 6, and we'll talk about how their roles differ. So on the next slide, we're going to talk about area 4, so the primary motor cortex, which is the red in the picture. So this is only active when there are movements being executed. So this area creates the nerve impulses that will travel down the corticospinal tract, which you guys probably looked at in semester 1, and then go to the muscles. So for contraction or movement. So this area also has the lowest electrical threshold for stimulating movement, which is important so that it can actually create those nerve impulses, but also means that, which we'll talk about later, but parts like the basal ganglia are important because they will suppress certain unwanted movements from happening. The key inputs into area 4 are area 6, which we'll talk about on the next slide, and then also sensory information. So area 6, this is made up of your premotor area or your PMA, as well as your supplementary motor area or your SMA. So this part feeds information to the area 4 that we talked about before, and it's responsible for determining what needs to be done before area 4 can actually generate those impulses. So the premotor area, that is more responsible for coding the actual goal that needs to be accomplished. So things like sensory information will input into that area so that your brain can use visual or auditory clues to aid in determining what it needs to do. And then there's the SMA, so the supplementary motor area. There's two parts. So there's the SMA proper, and that's involved in helping to plan a motor action, particularly from memory. And then the pre-SMA, which is more involved in acquiring or learning new motor skills or motor sequences. And the SMA proper, just anatomically, is more caudal. So if you look at the picture up the top right, you can see that caudal is kind of the more base of your skull. And then the pre-SMA is more rostral, so towards the front to your forehead. The second part of your brain that's important is the basal ganglia. And as I said before, this is involved in things like inhibiting unwanted movements. So the structure, we have 5 key parts. So they're all labeled on the diagram, but there's the striatum, which has 3 or 4 parts. So there's the globus pallidus, the externa and interna parts. So the interna would be the dark blue there, and the externa is the one right next to it. And then the putamen, the caudate nucleus, and then the subthalamic nucleus and substantia nigra are lower down. So how does it suppress or facilitate movement? So the basal ganglia has either via the direct pathway, it can have a net facilitatory effect on the cortex. So pretty much means that it promotes the cortex in producing those nerve impulses that will travel to your muscles. Or via the indirect pathway, it can have a suppressive effect on the cortex. So it'll stop it from sending off those nerve impulses. I'm not going to go through the diagram because I think it's better if you look at it yourself. So those red arrows pretty much mean that an inhibitory signal is being sent to the next one. And then the black arrow means an excitatory one. But if you follow from the cortex around, you'll see how the direct pathway, for example, will lead to activating the cortex, whereas the indirect pathway is going to lead to inhibiting the cortex. So the cerebellum is really important for coordination. So there's 3 main functions, and they'll all highlight how they all contribute to coordination. You should probably, that's just the main thing to know about the cerebellum. You'll come across this again in clinical skills as well, where a lot of the tests that you do for coordination are testing the functioning of the cerebellum. So there's 3 different key functions. So as I said, it modifies the motor plan so that it's coordinated. It also uses proprioception, so our sense of our body and its position in space, to make sure movements are more coordinated. And then it's also involved in timing those motor activities. So especially with sequential movements, it makes sure that we're progressing between those smoothly. So there's 3 different ways of categorizing the cerebellum and the parts of the cerebellum. So the first 2 ways are either by anatomy or function. And then on the next slide, we'll see how it's categorized by combining both anatomy and function. So solely looking at anatomy, there's the anterior lobe, the posterior lobe, and the flocculonodular lobe. So you can see those areas in the picture. But then if we take it by function, we have the vermis, intermediate zone, and then lateral zone. So the vermis, and by the way, the vermis is going to be in the middle. So we have 2 intermediate zones and then 2 lateral zones on either sides of the vermis. So the vermis is going to be involved in controlling the proximal body, and the intermediate zone, the more distal body, so things like your hands and your fingers. And then the lateral zone is going to be involved in planning those sequential movements and timing as well. And then if we combine anatomy and function, we get the vestibulocerebellum, the spinocerebellum, and then the cerebrocerebellum. So similar to the one where we differentiated by function, we have the vestibulocerebellum is important for the proximal body, then the spinocerebellum is the distal body, and then the cerebrocerebellum will be responsible for those sequential movements, timing, and coordination. And then in the bottom picture, there's just some additional functions of each of those parts. But for the vestibulocerebellum, you can see how its control of the proximal body is important for things like balance and posture and stuff, because those are more of part of your axial body.
So we're going to move on to clinical examination of the motor system. Before we get started, I just introduce myself because I'm new to the team. My name is Natania, and it's really nice to meet you guys. I just thought I'd let you know, please feel free to DM me with any sort of questions about whether the system or the systems in the future that I cover. On Facebook is totally all good, and if you need to look me up, it's a space instead of an apostrophe in my last name because Facebook thought I was a bot when I put in apostrophe. Yeah, so DM me anytime. But yeah, so we'll jump into this now. Just as Sayumi covered, that's the location of the motor cortex. And something to just have a look at here is that the sensory cortex is right near it as well, because of course, as we know, motor and sensory are, very interlinked. And next slide. Yep, so this here is just a diagram of a motor homunculus. Something that's important to note is if you look up like homunculus on Google or something like that, you'll have an option for a motor one or a sensory one, and these two vary. The homunculus is just sort of a diagram that is able to show you like the arrangement within your motor cortex of, what is controlled by which area of the cortex. So as you can see, there's a huge emphasis on the hand and the face. And there's also that diagram on the right side that just shows you that in sort of like in terms of the motor cortex itself. Okie doke, so we're going to move into upper and lower motor neurons. Just to know that when we're talking about central control within the body, we're talking about upper motor neurons. When we're talking about peripheral control, that's more lower motor neurons. And something to remember is that upper motor neurons will synapse with the lower ones at the spinal cord itself. And something else to keep in mind, as you can see in this diagram here, as we're traveling down through the brainstem and then through the spinal cord, you can see that the medulla is the lowest section of the brainstem. And within the medulla, you've got these areas called pyramids, and that is where the motor neuron will switch from the left side to the right side or the right side to the left. And that's why, when you're talking about, for example, your right hand, that will be controlled by the left side of your brain, or your left hand is the right side of your brain. So that's super important to remember. And that always happens at the medulla. Yep, so now we're going to move into examination specifically. So this is for your limbs, your motor examination. You always start off with observation for any of your examinations. Here we're looking for things like atrophy, hypertrophy. So that's, less muscle than you'd expect or more muscle, any sort of fasciculation, so involuntary movements or like tremors or any sort, symmetry in terms of both sides of the body, and any sort of involuntary movements that you're seeing. The next thing you'd like to look at is tone. So in this case, for when we're talking about muscle, tone means the amount of tension or resistance to movement that you would find. So here you're going to be doing sort of passive movements and active movements if they're able to as well. So you're doing supination and pronation of the forearm. You're going to focus on flexion and extension at the elbows and the wrists, and flexion and extension at the knee and ankle. So that's checking both arms and legs. If you were to have an upper motor neuron problem, then you would see increased tone in any of these areas. And if it was a lower motor neuron problem, that would be decreased tone. So you would have a less resistance. Yep, so moving on to power now. So when we're checking for power, we're always going to check from our proximal areas or proximal joints to our distal areas. This is the opposite in sensory, so that's something to remember as well. When you're checking sensory function, you're going to be going from distal to proximal instead. So when we're having a look at power here, you can see we have a particular grading system. So this is the MRC grading system. If you're rating it a 5, that means that the power level is normal. If you're going to 4, they're still capable of movement, but and this is against resistance, but it's not up to what they're usually capable of. If you're rating it a 3, you have got movement against gravity, but not against resistance. 2 is you've got movement, but not against gravity. 1 is you've got a flicker of movement, and of course 0 is no movement at all. I've just got a few different, I suppose, ways that you can remember different things to check. So I guess I'll just try to quickly go through them for you. So when we're having a look at our arms, you're testing chicken wings. So your patient has their arms out like this, and you're testing abduction and adduction. So you're going to push against here push against here as they're trying to come in. Do even lift bro is you're going to be focusing on elbow flexion and extension. So this way, again, with that resistance. The motorbike is you've got wrist flexion and extension with resistance. Tabletop is you're going to put their hands out like this. Once again, flexion and extension. Jazz hands on the tabletop is so you've got tabletop sort of situation, whereas you're looking at finger abduction. So while your hands are like this, their fingers are going to go out like this, and you're going to give them resistance to that. And then when you're testing finger adduction, this is one where it's a little bit different. Instead of a sort of movement pushing them in, that's a little hard to tell there. So instead of that, you're going to put a paper or a tissue or something in between their fingers and see if they're able to hold it in place. And then number 7, which is a sort of ready to fight stance here, and you're going to be testing their finger flexion and extension, whether they're able to curl in and whether they're able to stretch out, once again with that resistance. For fine finger movements, we're not really doing resistance, we're just sort of observing what they're capable of doing. So for example, playing the piano, just kind of these general finger movements and seeing how they go with that. The tapping is you're going to go from each finger and press it down to the thumb and do that for the other side as well. And then when we're moving on to the legs, this is going to be a little hard. We'll try it this way. So for the step is you've got hip flexion and extension as they're sitting down and they're going to raise it up and down. And again, with resistance either way. Splits is when their legs are going to go out in and you're going to give them resistance. Kick is when you've got your knee flexing and extending. And then the ballet one is you've got ankle movement here and you've got your foot going for dorsiflexion and plantar flexion the other way as well. And through all of this, you're going to have resistance to check their power. Yep, and now we're going to talk about reflexes here. So just something really quick to mention is if you're ever talking about the spinal reflex arc, what we're basically, in a nutshell, just talking about is the fact that sensory neurons don't go throughout the entire pathway. You've got that connection between sensory and motor neurons instead of one big neuron, I suppose. And that way you're able to have a much quicker process. Both sensory and motor neurons are able to work simultaneously and are able to get the body's messages a lot quicker. So that's just something to remember. And as we're talking about reflexes, I won't go through all of these because there's quite a few good videos online. I think Geeky Medics is quite good at different OSCE stations and that sort of thing. So just have a look at those ones there. But just thought I'd mention that jaw jerks and finger jerks, it's not normal to have them. And when you do have them, that's when we've got a problem here. And then the other one to remember is the plantar reflex, which is also known as the Babinski reflex. And there's a diagram of it here. So basically, if this is a foot here, you're going to run like the back end or the stick part of your reflex stick and it come across like this. And as it says here, if the big toe goes up instead of down, that means you've got an upper motor neuron problem. When you do the Babinski technique, you'll get that reflex. Moving on to clonus, that's just sort of like, say I've got a foot here, I'm just going to pull the ankle back rapidly like this. And if it keeps wobbling back and forth after you've done that, that's an upper motor neuron problem. Yep, and that's just a diagram of some of the reflexes for you to go through a bit later on if you'd like. Yep, so now we're going to talk about the specific things that you would see for an upper motor neuron problem or a lower motor neuron problem or lesion. So for upper motor neuron, you're going to see that in the upper limb, you'll have stronger flexion, and in the lower limb, you'll have stronger extension. You'll have increased muscle tone, hyperreflexia, extensor plantar reflex, which was the Babinski reflex, and you'll also have that clonus that we talked about. So that note there says that upper motor neuron influences are mostly inhibitory. So that's why you're going to get hyperreflexia, is because not only are the upper motor neurons in charge of the action itself, they're also super important to inhibiting the strength of that reflex or the strength of that movement. And so when you've got a problem within the upper motor neurons, those inhibitions aren't as strong as they need to be, and you'll have hyperreflexia or spasticity, which is kind of overactivity. And then for lower motor neurons, you've got weakness, atrophy, fasciculations. In particular, you see that with motor neuron disease. And you've also got hypertonia and hyperreflexia, so weaker reflexes and less muscle tone. Yep, so Sayumi already went through the basal ganglia, but we're just going to link it to something to talk here. So in particular, the part of the basal ganglia known as the substantia nigra is really important to discuss when we're talking about Parkinson's disease. So within the substantia nigra, in a patient who has Parkinson's, they're going to lose about 70 to 80% of their dopaminergic neurons, which are important to voluntary movement. And that's why you have that impairment within Parkinson's disease. And I think we'll talk about that a bit more in the next slide. Yep, okay, so just to jump to Parkinson's disease there, yep, that's known as a type of underactive movement disorder. So you're gonna get bradykinesia, which is very slow sort of movements. And a way for you to check that within a patient is if you kind of do this tipping can movement here and you ask them to do that quickly, you can kind of observe how slow they're gonna be able to do that. And that can really help you to make that diagnosis. For Parkinson's, you'll also see the patient has a rest tremor, which reduces when they try to move or they try to grab for something or something like that. They'll have very rigid movements. You're not really looking for weakness in particular or anything like that, but they'll have very small movements and a very, usually they'll have a quiet demeanor as well. And they'll also have impaired postural reflexes. So for example, if they're standing or they're trying to stand still, they may potentially have a bit of trouble with that, may start to fall over. The other thing to look at here is Huntington's disease, which is kind of the opposite of this. You've got an overactive movement disorder. So you're going to get a lot of involuntary movements. You can also have quite a obvious cognitive decline. Patients can have a bit of mental disturbance, and eventually a lot of them do become diagnosed with early dementia. Yep, and just this bit here, I think again, Sayumi talked about the cerebellum a little bit, but just to kind of link that to what we've been talking about, as the cerebellum has a huge role in controlling voluntary movements and coordination. If you have any sort of cerebellar problems, some of the clinical signs you would see is incoordination, hypertonia once again. They probably have like a normal power, but you would see that within their reflexes, their reaction or their reflex would be a very sort of pendulum effect. So rather than just one straight movement, it would kind of, flop back and forth. So once again, think that pendulum. And other sort of clinical signs you would see is slurred speech, rapid jerky eye movements. So these are all sorts of things to look out for. And as you can see, a lot of them sort of overlap between different types of problems within the motor system. But that's why it's super important to try and cover all these bases so that you're able to find specific criteria for specific diseases.
All right, I'll be talking about upper limb and a bit of CLIN skills as well. So this will finish off the anatomy component for this block of the MSK system. And as always, feel free to fire me any questions that you have. I'd love to have a go at answering them. So what we talked about last week was, I guess, an introduction to anatomy and some of the terminology that we used. And I guess we'll revise some of the terms that we talked about last week. And last week, we were primarily talking about the shoulder and the axilla. So that pyramidal shaped structure between your armpit and your neck, and that transports or transmits a lot of important structures into your arm. And what we'll cover today is the actual anatomy of the arm. And we split that up into upper arm, which is from your elbow to your shoulder, your forearm from your elbow to your wrist, and then your hand. Okay. So I find when we can divide it up into those three main sections, what actually works quite nicely is that the muscles tend to be separate between upper arm, forearm, and hand. And lots of other things are actually distinct in those regions. Okay, so I'll start just by talking about the upper arm, and we'll work our way down to the hand eventually. So here on the right, I've got a cross section of your upper arm, and you can see there's only one bone. And we talked about that bone last week, which is the humerus. And just remember that bone articulates or connects with proximally as part of your shoulder joint. So that articulates with the glenoid fossa. Okay, that's the one bone in your upper arm, and that runs down to form some of your elbow joint. Okay. The other thing that you may have heard of is this thing called fascia. And fascia is sort of like a strong connective tissue covering. You can think of it a little bit like guess, a glad wrap, which is a sort of strong material. And it basically covers lots of the important structures, just so you don't have organs directly contacting your skin, for example. And when we talk about fascia, we often talk about a superficial fascia and a deep fascia. And so our superficial fascia will often run just inside the border of the skin, so around just under the skin, and that's why we describe it as superficial. Whereas our deep fascia often interconnects structures. So here it forms connections with the bone and the superficial fascia. Okay, so our superficial fascia is sort of a big encasing structure, where our deeper fascia divides up our superfascia into what we call compartments. And compartments are really cool. We see them in the upper limb and the lower limb. And basically, your deep fascia connects your superficial fascia to the humerus, and that forms in your upper arm an anterior compartment, so lying towards the forward part of your body, and a posterior compartment. And we've got muscles and blood vessels and nerves that are always sort of stay in different compartments, right? So the blood vessels in the anterior compartment will supply the anterior muscles, and vice versa. Okay, so when you break it down into compartments, it can simplify things a little bit more for you. So when we talk about the anterior compartment, that's going to contain your biceps, coracobrachialis, and brachialis, so 3 muscles, and they all have the shared function of contributing to elbow flexion. Now, it's worthwhile thinking where some of these muscles are, because a muscle that crosses a joint will move that joint. So your biceps actually originates from your scapula and inserts in your forearm. So that crosses both your shoulder and your elbow joints. So that actually flexes both of them. Whereas your coracobrachialis, if you can remember the coracoid process of the scapula, brachialis, brachio meaning arm. So it starts from the coracoid, inserts on the arm. That just crosses your shoulder joint. So that's only going to flex the shoulder. Whereas brachialis actually originates from your upper arm and inserts in your forearm. So that only crosses the elbow joint, and that's only going to do elbow flexion. But those 3 muscles make up the anterior compartment, and they'll all perform elbow flexion, except for the coracobrachialis. The other things in terms of neurovasculature is your median, ulnar, and musculocutaneous nerves will all remain in that anterior compartment, and also your brachial artery will run there too. In the posterior compartment, the good thing is it's just the one muscle, it's the triceps. And so the anterior compartments here, we've got 3 heads of the triceps, which is what's called triceps, whereas biceps, bi meaning 2, so you have a long head and a short head. Okay, it's also worthwhile thinking that the anterior compartment is quite a bit bigger because you've got 3 muscles compared to 1. And in the posterior compartment, we'll have the radial nerve and the profunda brachii artery. Profunda means deep. Okay, so with our muscles, all the anterior compartment muscles are innervated by the musculocutaneous nerve. So you can section off the information in the compartments pretty nicely and say that anterior compartment muscles perform flexion, and they are innervated by the musculocutaneous nerve. Remember, they move the joints that they cross. So depending on where they originate and insert, and you can look at a few diagrams that will tell you what joints they move. But it's all flexion. Now, it can be hard to visualize, but we see the 2 heads of the biceps here, and coracobrachialis is this green muscle underneath, and we've got brachialis, which is just underneath the biceps. So both of those are actually deep to the biceps muscle. So they're actually beneath it. And coracobrachialis is going to be in the proximal half of your humerus, and brachialis is in the distal half. Okay, so coracobrachialis is going to act on the shoulder, whilst the brachialis muscle will act on the elbow. This long head of biceps is important because that actually runs in the intertubercular groove. If you can remember, the humerus has a greater and a lesser tubercle. And so that groove that sits in between them is actually holds the long head of the biceps muscle. Okay, and there's a couple of additional functions. We'll talk about supination when we get to the forearm, and the coracobrachialis, because it's located medially, will have some role in adduction of the shoulder. Triceps, obviously being in the posterior compartment, if you think about where the muscle is located, if you pull down on its insertion, it's going to pull your arm backwards. So that's got a role in extension. and it's got 3 heads, long, lateral, and medial, and that's going to be innervated by the radial nerve, which is the only nerve in the posterior compartment. So anterior muscles are flexion and posterior muscles are extension. So that's pretty much the upper arm covered for muscles. Now we get to the bones of the elbow joint. And as I mentioned, the humerus is the only bone in your upper arm. So that has to connect with some other bone at the elbow joint, and those are the bones of the forearm. So your bones of the forearm, there's only 2 that we need to talk about. We've got the radius and the ulna. Okay, so the distal humerus will articulate or connect with, form a joint with the radius and the ulna. It's a synovial hinge joint. Hinge joints permit flexion and extension. So we can't actually rotate or adduct our elbow. It's simply just flexion and extension. And synovial joints, as I talked about last week, are the joints that are going to make up all of our musculoskeletal system. Now we've got a lateral epicondyle and medial epicondyle, which are bony landmarks of the humerus. And epi, I guess, means lying above, and the condyle. So when we think about the condyles, we've got the capitulum, which is this blue region here, and the trochlea here. So they're parts of the humerus which actually articulate with the radius and ulna. Okay, so these are our condyles, and then these bony prominences either side of our condyles are called the medial and lateral epicondyles, and they're important because lots of muscles originate from those points. We also have a few fossae. So we have got the olecranon fossa, the coronoid fossa, and the radial fossa. And each of those fossae have fat pads, and those fat pads act as cushions when bones from the forearm enter them when you move your elbow. So when you flex and extend your elbow, the actual bones of the forearm will move into those fat pads. And the good thing is the actual names of those fat pads and the names of those fossae correspond to the actual parts of the bones of the radius and ulna. So the olecranon fossa of your humerus, which is located posteriorly, that connects with the olecranon of the ulna. The radial fossa connects with the radius, and the coronoid fossa connects with the coronoid process of your ulna. Just from this diagram here, you can see that the radius is a lot smaller than the ulna at the elbow joint, and we actually call the part of the radius that articulates the head of the radius, whereas we're looking at the trochlear notch of the ulna, which articulates with the trochlea of the humerus. So all the names match up there, which can be helpful. With our distal humerus, you can fracture any part of the humerus, but depending on the part that you fracture, there's going to be different structures at risk. Now, we talked about shoulder dislocation last week, and the consequences of shoulder dislocation are actually very similar to the consequences of a proximal fracture. So they're usually at the surgical neck of the humerus, which is just below the trochanters and the ball that makes up the ball and socket joint. And they're typically caused by trauma or a falling on an outstretched hand. And it's the same structures at risk, the axillary nerve and the circumflex arteries. And if you damage your axillary nerve, what does that innervate? Deltoid and teres minor. And so you're going to have impaired abduction, and you're going to lose a bit of sensation to your upper arm. If you injure your humerus at the midshaft, so about halfway between the elbow and shoulder joints, that typically occurs from direct trauma, and you're likely to fracture that anatomical landmark that we talked about, which was the radial groove. Now, what structures lie along the radial groove? Well, it's the radial nerve and the profunda brachii artery. Okay, so what structures does the radial nerve innervate? Well, it innervates lots of the extensors of not only your upper arm, but also your lower arm and hand as well. So you'll get what we call wrist drop, which is where you pretty much have a flexed hand, a flexed wrist, because you can't extend it, because the radial nerve is the only nerve that actually innervates your extensors. And you're going to get anesthesia, so lots of sensation to the dorsal hand, which is opposite the palm. If you injure your humerus distally, which we call a supracondylar fracture, meaning the fracture occurs above the condyles, that typically occurs due to a Fuchs injury. We can get extension fractures, which is where your elbow is extended. They occur more commonly than flexion fractures, and they're likely to impact the median nerve and the brachial artery. So it's a different set of vessels and nerves at each different site, And that really depends on where the vessel is close to the actual bone. So we've talked about the humerus. Now it's time to talk about the bones of the forearm. So we've got the radius and the ulna. Now, as I mentioned, the head of the radius, which is located proximally, is quite a bit smaller than the ulnar at the elbow joint, but it's actually opposite at the wrist joint. So the radius is a lot bigger distally, and the ulnar is a lot smaller. We have these styloid processes distally, which articulate with the wrist bones and form part of the wrist joints. And we've got a couple of notable tuberosities, which lie about halfway down between your elbow and wrist joints. And so your biceps is going to insert on a point on the radius called the radial tuberosity, which is here. And your brachialis muscle is going to insert on the tuberosity of ulna here. So if you're wondering where those upper arm muscles actually insert, it's quite proximally on tuberosities of the radius and ulna respectively. And these bones, the radius and ulna, actually have two joints with each other, and we call these joints the radio-ulnar joints. They're synovial, as all joints are, and they're pivot joints. So they allow rotation. So when you rotate, I guess, your wrist and your forearm, you're not actually moving it at the elbow, because that's a hinge joint and that can only do flexion and extension. You're actually doing movements that occur via your proximal and distal radio-ulnar joints. And of course, there's a few bony landmarks of the proximal ulna, which include the olecranon, trochlear, notch, and coronoid process. And hopefully you can match up some of those names to landmarks on the distal humerus. So that rotating movement of the forearm that I just talked about is what we call pronation and supination. I find the easiest way to remember supination is when you move your hands in a way that allows you to hold a bowl of soup, that movement is supination, whereas pronation is the opposite. So that gets you to a point where your palms are facing down. So supination allows you to hold the soup, and pronation is the opposite. Okay, and that movement isn't actually occurring at the elbow, that's actually occurring at the proximal and distal radio-ulnar joints. So the actual muscles that enable this all insert on the radius and actually pull it over the ulna. Okay, so we see in this diagram here, in the supine position, which is your anatomical position, everything looks fairly normal. But when we talk about pronation, all the muscles that insert on the radius will actually pull it over and bring it over the ulna. Okay, so that actually overlaps. The muscles that enable pronation are pronator teres and pronator quadratus. And the muscles that enable supination are biceps brachii and supinator. So there's two muscles that do each. And if you think about the biceps, that originates up in the shoulder joint, and that's going to insert on your radius, right? So because it inserts on the radius, when it pulls in the supine position, it actually pulls the radius back into its anatomical position. So I think biceps is a really important one to remember in terms of supination, because all the other names match their actual function. So that's pretty much the upper arm done. It's just about remembering the different compartments, what muscles lie in those compartments, and each compartment is related to a specific movement and has its own innervation, which is pretty nice. Now we'll head into the forearm, and there's a ton of muscles in the forearm, okay? Upper arm is pretty nice because there's just the 3 in the anterior compartment and 1 in the posterior compartment. The compartments are actually maintained in the forearm, but you think we can move our hand in so many different ways. And a lot of the muscles that move your hand are actually going to originate in the forearm because they'll actually move your wrist as well. So we have a bunch of different anterior muscles, and like in the upper arm, their role is generally going to be wrist flexion, okay? Because they're going to start in the anterior compartment of your forearm and they're going to cross the wrist, and they're going to, when they contract, they're going to move the wrist into a flexed position. They're generally innervated by the median nerve. The exceptions to that are flexor carpi ulnaris and half of flexor digitorum profundus. Okay, so I'll just run through these muscles. So we've got pronator teres, flexor carpi radialis, palmaris longus, and flexor carpi ulnaris. Pronator teres, as we've talked about, does pronation. Now, carpi means wrist, and radialis and ulnaris, that actually refers to the actual sides of the arm that you're on. So remember the radius, and that bone actually is located laterally. So the radius is the bone on your thumb side, and the ulna is the bone on your pinky side. So that's located medially. And flexor carpi radialis is just the flexor of the wrist on the radial side, and vice versa for flexor carpi ulnaris. We've got flexor digitorum superficialis and profundus, which means deep. So you've got superficial and deep muscles that flex your digits, and pollicis means thumb. So you're flexing the thumb. It's called flexor pollicis longus because there's also a flexor pollicis brevis, which means short, and that's located in the hand. And we've got pronator quadratus as well, which is another muscle that causes pronation. Okay, so how I like to remember the muscles that are innervated by the medial nerve and the ulnar nerve, everything's innervated by the medial nerve, except the muscles that are actually located on the ulnar side of the forearm. So flexor carpi ulnaris is innervated by the ulnar nerve because that actually runs on the medial forearm. And the half of flexor digitorum profundus is actually the two segments of the muscle that innervates your two ulnar digits. So the sections that flex the pinky and the fourth finger are innervated by the ulnar nerve. So basically, lots of your medial forearm is going to be innervated by that ulnar nerve, and those are the two muscles that are located most medially. One way you don't really need to remember the different layers. So on the left is most superficial, then a middle layer and a deep layer. Don't need to know that. If you're interested, a nice way of remembering the order of the superficial layers is PF, where you've got pronator teres, flexor carpi radialis, palmaris longus, and flexor carpi ulnaris. And you can use the actual name to tell you which order they run, because ulnaris is going to be on the ulnar side, and pronator teres actually has to insert on the radius because it causes pronation. Okay, then there's a lot of posterior muscles as well. You note that lots of them are called extensor because the posterior compartment of the wrist performs wrist extension. And again, it's innervated by the radial nerve. So remember we said radial nerve damage at the radial groove will cause wrist drop. That's because it innervates all the extensors of your wrist. The one exception that's probably worthwhile knowing is brachioradialis. And that was a muscle that actually originated in the upper arm, and that's inserts on the ulna. Sorry, that's brachialis. Brachioradialis is a different muscle. Now, brachio and radialis, meaning it's going to start insert on your arm and insert on your radius. So originates from your arm, inserts on the radius. And it's a posterior muscle that performs elbow flexion. So this is the one exception to all the rules that we've been talking about. Generally, it's posterior equals extension, anterior is flexion. But brachioradialis is a posterior muscle that performs elbow flexion. Okay, and again, there's a bunch of different muscles. Their names can tell you, give you cues on their function, but you definitely don't need to know their origins and insertions. It just can be helpful to know what they do, and often the name gives that away. Now, something that's worthwhile knowing about is epicondylitis, right? If I just take you back 2 slides, you would have noticed on this left image here, all of these flexor muscles originate from the same spot, right? And it's a nice thing to know that generally your flexor muscles of the forearm will originate from your medial epicondyle of your humerus, and the extensor tendons will originate from your lateral epicondyle. Okay, so when we have inflammation of the epicondyle, that often occurs from overuse, and medial epicondylitis, which is called golfer's elbow, is inflammation of the flexor tendons, whereas lateral epicondylitis or tennis elbow is inflammation of the extensor tendons. I think this is something that's worthwhile knowing because generally the conditions come up more than the actual anatomical questions. We also have olecranon bursitis. Just remember, a bursa is like a fluid-filled sac that decreases the friction between different structures. It's called student's elbow because sometimes when you study, you're leaning on this olecranon, which is the big bump at the back of the elbow. And if you're leaning on it for too long, structures get rubbed together and they get inflamed. And if you're leaning on your elbow during study, you might actually get this olecranon bursitis. Now, we've talked about bones and muscles. Now it's time to talk about important regions. And probably the most important region in your forearm is the cubital fossa. Now, this is a triangular area which lies anterior to your elbow joint. Its borders are a line between the epicondyles, which is sort of a hypothetical line, pronator teres medially, and laterally we have brachioradialis. Okay, and you can see a sort of triangle shape emerging between them. Just remember that the superior border is an imaginary line, right? So we've got pronator teres, brachioradialis, and a supracondylar line. And a lot of important structures travel through this cubital fossa. So we've got the radial nerve, the biceps tendon, the brachial artery, and the median nerve. Generally speaking, the brachial artery and the median nerve run very close to each other, as do the radial nerve and the profunda brachii artery, as do the axillary nerve and the circumflex arteries, which are in your shoulder. So, if you damage one, you're quite likely to damage another. This brachial artery actually splits at the cubital fossa into your ulnar and radial arteries, named so because they associate with the respective bone, which is a nice trick to remember. And this biceps tendon, which we've talked about, inserts on the radial tuberosity, that forms what we call an aponeurosis before it inserts. So rather than just being one string that inserts on a point, it actually forms a sort of sheet of tendons that all inserts on a point. Okay, so rather than just being like one particular point, it sort of fans out and inserts along quite a large region. Now we have the wrist and the hand. Okay, so there's a lot of different bones in your wrist and hand. There haven't been a lot in the forearm and the upper arm, but particularly your wrist, there's quite a lot that you need to know. But there's always ways you can break it down. The wrist joint is a synovial condyloid joint. So a condyloid joint is going to permit quite a few movements. So we can have flexion, we can have extension, we can do abduction, adduction, and we can also do what we call circumduction, which sort of moves the joint in a circle, right? You can't do internal and external rotation of your wrist. That's pronation and supination, which is why it's not a ball and socket joint. You might notice with wrist abduction, that moves your wrist to the thumb side. You can't really do it that far. And adduction moves your wrist to your medial side. Those movements are actually performed by flexor carpi radialis, which is abduction, and flexor carpi ulnaris, which is adduction, and the extensor muscles as well. So extensor and flexor carpi radialis will do abduction, and extensor and flexor carpi ulnaris will do adduction. So just the ulnar muscles will move the wrist to the ulnar side, which is nice to know. The wrist joint is actually formed between your radius, which is much bigger distally, your scaphoid, which is an important bone in your wrist, and your lunate, which is another bone in your wrist. The ulna actually doesn't really make up this joint. There's a disc of cartilage here that it actually interacts with. And so it's actually not technically part of the wrist joint, according to some sites. But you will notice that the ulna and radius sort of connect with each other here, and that's the distal radio-ulnar joint. It's one of the joints that enables pronation and supination. So the actual bones of the wrist, there's 8 bones that we need to think about, right? And we have the trapezoid, trapezium, capitate, scaphoid, lunate, pisiform, triquetral, and hamate. Remember, carpus means wrist. And how can you remember them? Well, I always remember that the scaphoid is part of the wrist joint. So the scaphoid is a bone that sits just about here near the thumb. Then it has the lunate just next to it, and the other bone that's going to lie near there is the triquetral bone. So we sort of have 3 bones in what we call the bottom row. The pisiform bone is quite hard to see, and it's a very sort of small bone that lies near the triquetral. So this bottom row of 4 is the scaphoid, lunate, triquetral, and pisiform. And then we have a top row, which is your trapezium. I sort of remember that as, if you think about a trapezium, you can sort of slot a trapezium into the side, and it might be able to fit more nicely if it's a trapezium. So the trapezium goes to the side, then we have a trapezoid and capitate and hamate. So I like to think about there's 4 bones in the bottom row, 4 bones in the top row. If you can remember which bones are on which side, then it generally makes it a little bit easier. But definitely look up a couple of diagrams other than this one. And when you learn about different structures, like what the ligaments attach to, then the bones start to make a lot more sense. The actual fingers are not too bad. So it's just the wrist bit that's a bit annoying, because each finger has a metacarpal, a proximal phalanx, a middle phalanx, and a distal phalanx, except for the thumb, which has a proximal and distal phalanx, so no middle phalanx. And so, yeah, we've got your carpal bones, which are your wrist bones, metacarpal bones, and then your phalanges, or your proximal, middle, and distal phalanxes. So that's bones. Now we've got the different movements. And most of the time, it's fairly straightforward to think about what flexion and extension looks like, but it can get pretty tricky when we think about the fingers. So I've talked about wrist adduction and abduction, which you can also describe as ulnar deviation and radial deviation respectively, which may help make it a little bit more easy to understand. Circumduction, as I mentioned, is a circular movement of a body part. So it combines flexion, extension, abduction, and abduction. But what I really want to cast your attention to is the movements of the thumb, okay? Because these can be quite tricky. When we think about the fingers, flexion and extension sort of follow a normal suit, right? So I can flex my fingers by decreasing the angle between 2 body parts, and extension is the opposite of that, right? But with the thumb sort of sits on a different plane to your fingers, right? If we're in normal anatomical position, when we flex our fingers, they move anteriorly. But when we actually flex our thumb, flexion moves the thumb across, right? So I guess you can think about when you make a fist, and if you put your thumb sort of on the inside maybe, then that's a flexion of all 5 of your digits. So flexion actually moves your thumb towards the middle of your palm, and extension moves it the other way. Then we also have abduction and adduction of your thumb, right? And if your hand is flat, abduction will move your thumb away. So abduction actually moves it anteriorly, and it moves it away from your palm. It's probably easier at this angle. Abduction moves it away, adduction moves it closer by, whereas flexion moves it across into the middle of your hand, like it does with all the other fingers, and extension moves it the other way. Opposition and reposition. Opposition just means when you touch your fingers together, that movement is not really in any particular plane. We call opposition, and reposition is the opposite. So move them together, that's the opposition, and away is reposition. But the key thing with the thumb is, can you tell the difference between flexion and extension and abduction and adduction? And yeah, as always, let me know if you have any questions about any of those movements. The hand muscles are a really similar story to your forearm muscles. There's probably too many to know the origin and insertion of them all, but if you know what each one does, it helps. And the key to knowing what each one does is it's in the name. You just need to know what a couple of these words mean. So if I can refresh your memory, pollicis means thumb. And then when we talk about digiti, that means fingers, not including your thumb. And digiti minimi means your pinky. Okay, so we can group our hand muscles into thenar muscles and hypothenar muscles and a couple of other muscles. Thenar muscles act on your thumb, hypothenar muscles act on your pinky. So if you think about your palm, you might notice a little swelling of tissue sort of around the base of the thumb. That's where your hypothenar muscles are, and that point's actually called your hypothenar eminence. Whereas sort of on the medial side of your hand, you might notice a little bit of a tender tissue here. That's where your hypothenar muscles are. And your thenar muscles can consist of your opponens pollicis, abductor pollicis, and flexor pollicis brevis. Remember, we had flexor pollicis longus in the forearm, and they perform opposition, abduction, and flexion respectively of the thumb. Hypothenar muscles are the opponens, abductor, and flexor digiti minimi muscles. Again, the exact same function, just on the pinky. And they form the thenar eminence and the hypothenar eminence. The trick here is adductor pollicis, so it adducts the thumb. It's part of the thenar eminence, but it's not considered a thenar muscle because it has a different innervation. And we'll talk about innervation of these muscles in just a minute, but adductor pollicis is the actual exception to the rule. Now, aside from the thenar and hypothenar muscles, we have a bunch of muscles that act between the digits. So we have the lumbricals first, and their role is to flex the metacarpophalangeal joints and extend the distal interphalangeal joints. So if you think about the bones of your hand, the metacarpophalangeal joints are the joints between the metacarpals and the proximal phalanges. Then we have a proximal interphalangeal joint between your proximal phalange and your middle phalanx, and a distal joint between your middle phalanx and your distal phalanx. Okay, and so the lumbrical, they sort of make your fingers perform a L-shaped movement, which is sort of hard to do, where this joint is flexed, but the end of the joint is extended. So that they sort of perform this sort of movement there. Then we have interossi, and we have palmar and dorsal interossi. Your palmar interossi will perform adduction, and your dorsal interossi will perform abduction. Now, with your fingers, it can be quite hard, because with shoulder, for example, abduction moves your shoulder or moves your limb away from your body. But there's no real movement that moves all of your fingers away from your body. So it's more when you think about the midline or the center of your hand, abduction moves your fingers away from the middle, so it fans everything out, and abduction brings them all together. So this is abduction and this is adduction. Okay, your palmar interossi cause adduction, your dorsal interossi cause abduction. And you can remember this by remembering pad dab. I guess the two D's are in the middle as well, in case you think pab dad, but it's pad dab. The palmar do adduction, dorsal do abduction. We have palmaris brevis, which contracts to fold the skin of the hypothenar eminence. That's sort of located around here. It's not very important, but just so you know, wherever there's a longus, there's a brevis. There's a palmaris longus in your forearm. There's a palmaris brevis in your hand. And the flexor digitorum superficialis muscle, that will flex your wrist, metacarpophalangeal and proximal interphalangeal joints, whereas the flexor digitorum profundus joint muscle will flex the wrist, metacarpophalangeal joints, and the distal interphalangeal joints. So it's often that the deeper muscle actually is longer, and we see here it goes all the way and it actually inserts on the distal phalanges, so it can actually act on this distal joint. So the deep muscle acts on the dip, and the superficial muscle will act on the pip. Now, here's the innervation of the hand, and there's three main nerves that we need to think about. But basically, hopefully now you have an overview of what most of the key nerves do. With your hand muscles, they are all your median nerve innervates the half-loaf muscles. Okay, the half-loaf muscles, the half-loaf half muscles, which you might want to call them, but it doesn't roll as nicely off the tongue. And the ulnar nerve innervates the rest. So what are the half-loaf half muscles? Where it's half of the lumbricals, opponens pollicis, abductor pollicis, and half of flexor pollicis brevis. Adductor pollicis, which is the ulnar graveyard, remember that's the exception to the rule. So that's it lies in your thenar eminence, but it's actually innervated by your ulnar nerve, despite being a thenar muscle, which is the exception to the rule. But if you think about the medial two lumbricals, the opponens pollicis, abductor pollicis, and half of flexor pollicis, they generally all lie, I guess, towards the thumb side. Whereas the ulnar nerve will probably do most of the innervation to your medial hand, right? And this picture here shows the actual cutaneous, so skin supply of each nerve. And the median nerve is going to do most of the anterior hand. The radial nerve is going to do most of the posterior hand. And the ulnar nerve is just going to do pretty much the ulnar side. So the lateral or the medial 1.5 digits is the ulnar nerve. And we say, that the lateral 3.5 will be median or radial nerve. You don't really need to know the actual branches. I think just knowing that, medial does this area, radial does this, and ulnar does the medial 1.5 digits. So I think you can really nicely categorize each of the 5 terminal branches of the brachial plexus by their motory and sensory supply. So the musculocutaneous nerve, which has roots C5 to 7, that innervates the anterior compartment of your arm and has a sensory supply to your lateral forearm. The axillary nerve, which is around the shoulder, that innervates the deltoid and teres minor muscle and supplies an area of skin around the shoulder called the regimental badge. Your radial nerve, which runs in the posterior compartments, that innervates all the posterior muscles, and it will actually supply skin to the posterior compartments as well as the lateral hand on the back. Your median nerve will innervate generally your anterior compartment of your forearm, with a couple of exceptions, which are the muscles that lie really medially, and those are innervated by the ulnar nerve. And median and ulnar nerve will innervate most of the hand muscles, or the hand muscles, but split between the two. And the sensory supply matches sort of where they run. So ulnar nerve runs medially, that will supply the medial hand, for example. One important anatomical area of the wrist is the carpal tunnel, and basically it's the avenue to the hand for our neurovasculature and our muscle tendons. So it's the entrance to the hand from the forearm. So we have a bunch of carpal bones which form the floor of this tunnel, and the roof is actually a ligament called the flexor retinaculum. So it's a roof that connects these bones. And if you know, I guess, the points of contact of the flexor retinaculum, it can help you figure out like which of the carpal bones lies where. For example, it'll insert on the hook of hamate, so you can figure out where the hook of hamate is and work out it's on the pinky side. But certainly knowing the different carpal bones is a useful thing to know. You probably won't get asked on it in an exam, but it's definitely something you'll need to know in the future, and for CLIN skills potentially. So what actually goes through this carpal tunnel? Well, it's the median nerve and the flexor tendon. So we've got 8 tendons here, and then plus 1 on the side. The 4 here are flexor digitorum superficialis. We've got 4 here, which are for flexor digitorum profundus. And I'd say the one here is flexor pollicis longus. So long flexor tendons from the forearm will all enter through this carpal tunnel. The ulnar nerve and artery, they run up here through a separate compartment called Guyon's canal. Okay, so that's located above the flexor retinaculum. Now, carpal tunnel syndrome, I believe, is the most common peripheral neuropathy. It's the most common way of having some sort of damage to your nerves. And that's when the median nerve gets compressed in this tunnel, because everything's condensed. And if any of these tendons become inflamed, space is compromised and you're going to have irritation of that median nerve. What's the consequence of that? Well, you lose your sensory loss, and the median nerve supplies your lateral 3.5 digits, and you'll lose your motor supply to the half lobe and half muscles. So that will lead to wasting of your thenar eminence because they won't be used. So fractures, fluid retention, autoimmune disorders, hypertension, which is high blood pressure, and more can cause carpal tunnel syndrome. Okay, but it's one of the most common peripheral neuropathies. Cubital tunnel syndrome is pretty much the exact same thing, but at the elbow and with the ulnar nerve. It's also very, very common peripheral neuropathy. And if you flex your elbow, there's 2 bony landmarks that you can feel quite nicely. One just is the massive bony landmark right at the back. That's your olecranon. And if you go to the medial side, there's another bony landmark here, which is your medial epicondyle. So you can actually feel your epicondyles quite easily at your elbow. And in between your olecranon and your median epicondyle, if you press down there, there's actually a groove there. And that groove is where the ulnar nerve runs. So if you ever hit around there, you might get a funny sort of sensation. That's your ulnar nerve being irritated. So if you have continual pressure here, that can compress the ulnar nerve and cause damage. And that actually causes what we call ulnar claw, which will impact your 4th and 5th digits. So digits go from the thumb and go 1, 2, 3, 4, 5. So your 4th and 5th digits are on the medial side, which is where the ulnar nerve runs. So when we talk about neuropathies, we're talking about damage to nerve. If you have median nerve damage at the elbow, you present with something called the hand of benediction, which is where you can't flex the 1st and 3rd joints on your first 2 fingers. Okay, so that's going to impact your thumb and index finger, and consequently your 3rd finger might be involved as well. But the key point is it won't impact the 4th and 5th fingers because they're innervated by the ulnar nerve, right? If you injure your median nerve at the wrist, it'll just impact your thumb. So you get what we call APAN. That's because in the forearm, your median nerve's already supplied those muscles, right? But the actual thumb muscles are in the hand. So if you injure it at the wrist, you still have the forearm muscles, but you don't have the hand muscles. On the claw, which is what we see in this picture here, that impacts your fourth and fifth fingers. And it's caused by paralysis of your lumbrical muscles. So it's sort of the opposite to the L shape. You get a hyperextended metacarpophalangeal joint, which is where there's too much extension and almost moves backward like that. And you'll get flexed hips and dips. So your finger will actually sort of move back in the socket, and these distal joints will all be flexed. And that's what that looks like. So the difference in ulnar and median nerve injury is really like which fingers are impacted. And this is an example of wrist drop, which is where you can't extend your wrist because your radial nerve's injured. Probably the last space that we need to talk about is the anatomical snuff box. And this is a pretty cool one because you can actually see this pretty nicely. It's a triangular depression in the dorsum of your hand. So I guess if you put your hand out and it matches the position here, and then you sort of move your thumb towards yourself, you'll see that your tendons actually make a little bit of an angle with each other, and it looks something like this. Some people have it clearer than others, but that gap between the tendons is called the anatomical snuff box. Now, the borders of that are your extensor pollicis brevis, your abductor pollicis, and your extensor pollicis longus tendons. Okay, so remember pollicis meaning thumb. So they're the extensors and the abductors of your thumb. Now, why is this place important? Well, there's a bunch of important structures that run near or close to the anatomical snuff box. And these are the radial nerve, the radial artery, and the cephalic vein. So remember, your radius is your thumb side. So your radial artery is going to be running around there. You can probably feel your radial pulse quite close to the anatomical snuff box. I like to remember that the cephalic vein is located laterally because it goes through this snuff box, whereas the basilic vein is located medially. And the radial nerve actually will innervate the dorsum of your hand, at least the lateral side, by going through this snuff box as well. So pretty cool to remember the relationships between different structures. One thing that's really important is scaphoid fracture. And this is a bone in your wrist. It's one of the carpal bones that actually forms the wrist joint and is located laterally, and it articulates with your radius. So the scaphoid fracture, why it's important is it actually has what we call a retrograde blood supply. So it means backward. So if we think, to orientate you, this is probably like the hand is sort of this way. So if I draw a hand like this, the fingers are towards the top of this image and the wrist is towards the bottom. So this area is the distal area, and this area down here is the proximal area. So when we say retrograde blood supply, we mean that the blood actually starts distally and actually runs backwards proximally. So the blood in the scaphoid runs distal to proximal. And why is that important? Well, if we fracture the scaphoid here, then sure, we'll still have blood supply to the distal fragment, but there's no real blood vessels to this section of the scaphoid, this proximal section of the scaphoid. And so that's at risk of what we call avascular necrosis, which is death of tissue due to a lack of blood supply. So the scaphoid fracture has a massive risk of avascular necrosis because the blood flow is backwards. And if you have a fracture and it impacts this artery, then your flow to the proximal part of the scaphoid is significantly compromised. If you want to do some further reading with your anatomy, you can look at the ligaments of each joint, which I haven't talked about. They're not massively important. It's quite complicated. Monteggia and Galeazzi fractions are radioulnar fractions. Smith and Coles fractures are relevant to your wrist, and we've got a couple of nerve palsies as well. Last year's PSP went through these. Personally, I've never seen them on any exam question, but if you are interested in them, feel free to have a look at what they're about. I think Teach Me Anatomy's got a couple of good pages on them too. So that's it for anatomy. Again, ask me any questions you have, but I'll wrap up today by talking about clinical skills and the examination of your shoulder. Okay, so I talked about histories last week, and now we're talking about examinations. And so there's a bit of an introduction that I need to go through. just your overall process when you're trying to treat a patient is to start off with a history. The bulk of your diagnosis are formed from the history. With your history, you'll then likely go to an examination where you're following up any sort of differential diagnosis that you've made. So any, like what you think is the most likely diagnoses, and it can be multiple. After your examination, you might suspect a certain condition. You can follow that up with investigations, and often the investigations will give you something objective that you can use to actually form a diagnosis. But most of your heavy work is done in the history, actually, with your quick thinking. Because if you don't take a good history, you won't know what to examine. So what are the steps in an examination? Well, you'll hear this a lot, but hand hygiene before and after is going to be important. But you need to pretty much tell the patient what you're going to be doing at each time, and get them to be comfortable with it. So if you're doing an examination of the shoulder, you need to talk about the actual exposure, how much skin they're going to have to show, what exactly you're going to do in this examination, because they're going to have to do a lot of the movement, so don't keep them in the dark. Try and explain things to the best of your ability. So you start by introducing yourself, get the patient's details and the exam. Then you look at some general appearance. So before you actually get into anything, you just observe the patient, right? Are they grimacing? Do they have abnormal posture, things like that? Then you're going to have a closer look at the site, have a feel around the site, move the site and measure how far or the range of movements, conduct some special tests, and then wrap up the exam and mention your findings to the patient. But at each stage, it's all about communicating what's going on to the patient and making sure they understand what you're trying to do and are comfortable with it. The other thing is you need to compare sides as you go to check for abnormalities or anatomical variations, because something might be different, but if you don't look at if they're just coming in with a complaint on one side, it could just be something that's an anatomical variation. And if it's present on both sides, then it might not be to do with their actual complaint, right? So always compare both sides. Some people have elevated muscle mass, some people have less, some people have elevated reflexes less. You don't know whether things are abnormal really just by looking at one side, because you need to check whether it's always been like that or it's just become like that due to a certain presenting complaint. So with your introduction, you're looking at hand hygiene, getting patient details, explaining the examination, so the different stages that I just mentioned, look, feel, move, measure, special tests, explain the exposure and the position that the patient will have to be in. So if you're doing a shoulder exam, you need the patient standing with their top off. Generally speaking, we expose the joint above and below. So, you'll need the elbow exposed and you'll need the neck exposed as well. But that's a good thing to remember, because if we are examining the wrist, we need the elbow exposed and the hand exposed, so you can wear, a singlet or something like that, or roll your sleeves up the full way. You explain confidentiality and consent as you do in a history, and ask if the patient's in any pain or discomfort. You've got to make sure they're comfortable. And after the exam, you thank the patient. You can tell them to get dressed again, summarize your findings to them. Obviously, the way you summarize to a patient is going to be different to the way you summarize to a doctor, with the terminology that you use, and then conduct hand hygiene at the end. So the middle of this exam is really where the important stuff lies. And we start with general appearance. So we're looking at the patient's body build or body habitus. This sort of refers to, I guess you can talk about muscle mass, weight, things like BMI, just any cues that you can pick up on from the patient's body build and habitus. You can observe them to see if there are any pain or distress. Are they writhing and rinsing? Posture or any aids that they're using. So when I presented with shoulder pain, I was holding my shoulder like this when I rocked up to the emergency department, and they were able to, just by observing me, to just get me in the sling pretty much straight away, right? So the patient's posture can be important. Do they have aids, things like crutches, things like that? And any deformity, can you see like a bone protruding from the skin? Does the muscles look wasted away on one side, right? So that's all things you can get just by looking at a patient from a reasonable distance. Then we're going to take a closer look. So some people call this step closer inspection. So you're going to look around this joint, and you're going to look again for deformity. Does it look any different? Other muscles wasted? Is there any swelling, scars, redness, rashes, or nodules or lumps? So I guess my tutor explains this as saying like, you know, DM, SS, RR, and then O could be other, DM, SS, RR, O, but, you know, you can have different mnemonics for things like that. After you look at the joint more closely, you're going to feel the joint. So you're going to feel the surface anatomy landmarks. And this is where knowing the anatomy that we've talked about for the last 2 weeks is going to be relevant, because you're going to actually have to feel for things like the coracoid process and feel for things like the acromion. And so if you know your surface anatomy, you'll be really confident with actually finding these structures. You'll also feel for temperature, so use the back of your hand just to feel around that site and check if it's, you know, warm or cold. That can give you information about blood supply. Tenderness can give you information about inflammation, and any swelling as well is something you can feel. Now, after you look and then feel, now we have to move the joint. So we'll get the patient to move the joint first, which is called active movements. And after that, we'll do passive movements. Active movements will test their muscles, and passive movements will test their joint. So you do the movement, like you're grabbing their arm and moving it around in passive movement. They're moving without you in active movement, but we do active first. And then you have to examine all the movements that the joint is capable of. So your elbow is just flexion and extension. Your shoulder, there's flexion, extension, abduction, adduction, internal and external rotation. Crepitus is crackling sound in a joint. I can feel it best with my knees, but not everyone has this. So yeah, I mean, you can look online for that, but I guess when you move the joint, when you, I guess, feel over it, you can feel a sort of cracking sensation, which is mostly just air bubbles. Passive movements shouldn't be performed after a recent injury, right? So if they've fractured something, you don't want to, you know, just grab their arm and then forcefully move it, which is why you do active movements first. You get a sense of what they're comfortable with. And while you're doing these movements, you want to try and pick up how far they're moving in terms of degrees and comparing it to normal values. So what are the surface anatomy landmarks of the shoulder? We talked about these last week. So have the SC joint and the AC joint, which are the two joints of your clavicle to the acromion and the sternum. Then you're also feeling the clavicle. So you can start at the SC joint and just feel along the clavicle until you get to the AC joint. You can feel a little ridge there. You need to feel the tuberosities of the humerus and the groove in between them, which is where the long head of biceps runs. The scapula, which is your shoulder blade. You can feel the crest of the spine. You can feel the acromion, the coracoid process, the space under the acromion, looking for any inflammation, and the inferior angle, which is the bottom of the scapula. Okay, so you just pretty much feel over all those sites. And normal movements that you expect are flexion to 180 degrees. So, I mean, you can move your shoulder all the way up. That's 180. You can move it 65 degrees backwards. You can move it internally 90 degrees. We'll talk about internal rotation later. But basically, if you have your elbows by your side, and you can sort of measure internal and external rotation off that. The trick is just moving it at the shoulder and not anywhere else. So you tuck your arms in, have your elbows by your side, and then you can get a sense that internal rotation is about 90 degrees and external rotation is about 65 degrees. Abduction is 90 degrees passively, but actively you can move it all the way to 180. The reason it's 90 degrees passively is because you stabilize their scapula, and if you don't move your scapula, you can't move your arm any more than 90 degrees in terms of abduction, because the other 90 requires your scapula to actually move. And adduction is to 50 degrees. That is tested by just bringing your hand across your body like this. The key with the shoulder is the special test. There's actually a lot of special tests, but if you know, I guess for an examination's sake, I won't go through all these special tests because you'll get a much better run through in CLIN Skills in person. But I think for an examination perspective, it can be useful to know just what muscles these tests test and the actual role and movement that's being tested. So we start with the Apley scratch test, and basically this is where you touch your opposite scapula from either side of your neck and around the back. And the movements of that testing are abduction and external rotation, and adduction and internal rotation. So it depends, like whether you reach across like this or this, they're different movements, right? But think about the muscles that perform those different movements at the shoulders. Then we have impingement tests, where we have we're looking for things like rotator cuff impingement. Okay, and you notice a lot of these tests actually look at the rotator cuff. So we have near sign, which is basically you flex your shoulder and you're looking for pain there. Hawkins test is internal rotation. The painful arc test, which is just abduction, that is again an impingement test. Hawkins test, your teacher will go through. Biceps function test, again, you're just flexing the biceps against resistance there. Apprehension test, external rotation and looks for shoulder instability. I think you can also call this one like the stop sign test, because your hand is in a stop sign and you stabilize the shoulder and push this hand back, which is the sort of external rotation side of things. And then we've got a bunch of resistant movements. So rather than doing a movement actively or doing a movement passively, they move, but you apply pressure the other way. So that's what we call resistant movements. So we do resisted abduction, which tests your supraspinatus muscle. We have the empty can or Job's test, which is where your hands are like you've poured out an empty can. Then that will test your supraspinatus and abduction. And then we have your lift-off test, which tests your subscapularis and internal rotation. It's really like all these functions, all these movements match the actual function of that muscle. And then we have resisted external rotation as well, which will look at infraspinatus and teres minor. So a bunch of different tests. You'll go through all of those in class, but from like your examination perspective, just useful to know what muscles are being assessed by those tests and what movements are being assessed. I've got pictures of each of these different tests from PS Platypus last year. Feel free to have a look at those as a bit of revision of your session. Okay, well, that concludes what we have to go through today. Thanks very much for coming, guys. It's been a really long stint. But yeah, again, if you have any questions, feel free to let us know, and we'll see you all next week for some more PS Pirates. Thanks, guys.